I'm sorry for that. So let me start. So let me first tell you about something about the course. Actually, this course is something different from other courses. In this course, what I do is I try to teach everyone or make idea of the candidates about some prompts. So for my past 3 years experience, what I have found, there are certain prompts from different systems which come every now and then. So I have identified the prompts from each system. I have identified about 80 prompts from the different systems like the neurology, like the gastroenterology, like the musculoskeletal system, and that's on. So in this course, I try to make idea about the prompts, about how to approach to a certain case, certain prompt, how to take history for each prompt. Then I distribute the cases among the candidates, and I give them the homework. And at the next session, I practice with them personally. And in this way, I cover actually about 250 cases. So you'll understand once I start the discussion about the course. So let's start. So before starting about the long clinical consultation, you have to understand about the mark sheet. In the PACES exam, station 2 and 5 covers the long clinical consultation. And this is one of the vital stations for passing the PACES exam. In this station, you are allotted 28 marks. So first you have to understood what the marking parameter of this station. Actually, PACES exam encompasses 7 skills. They are physical examination, identifying physical signs, clinical communication skill, differential diagnosis, clinical judgment, managing patient concern, and maintaining patient welfare. And long clinical consultation is one of the stations where every 7 skills for passing the PACES exam is assessed. So let me discuss one by one. But before discussing each skill, I want to discuss something special, that is CCCA. Do anyone have idea what does CCCA means? Okay. Actually, CCCA means C for confirm, and another C for cause or trigger. Then C comes for complication, and A for association. So you have to confirm from the history, from the physical examination, and from the investigation about the CCC and A. So how to do this? Let me give an example. Suppose you are given a prompt of swallowing difficulty. So from the history, first you have to confirm that this is swallowing difficulty. I will teach you how you have to confirm from the history that it is swallowing difficulty. Then you have to find out the cause or trigger of swallowing difficulty. Suppose in this case, the cause is myasthenia gravis. So this will be the cause or trigger of swallowing difficulty. Then you have to find out the complication of swallowing difficulty. So what can be the complication of swallowing difficulty? Can anyone share his experience? Any idea about that? Dr. Neha, Dr. Nujat, can you please share your idea about what can be the complication of swallowing difficulty?
Aspiration pneumonia.
Wonderful. Yes, aspiration pneumonia. And also, one of the important complication of swallowing difficulty is not able to maintaining nutrition. So from the history, you have to find out the complication. I will teach you how to find out the complication from the history. One complication is not able to maintain the nutrition. Another complication is aspiration pneumonia. And the fourth thing is association. So how to find out the association? Actually, dysphagia is one of the features of myasthenia gravis. So the other features of myasthenia gravis, like the double vision, like the respiratory failure, this will be the association of swallowing difficulty here. And apart from that, myasthenia gravis is an autoimmune disease. So you have to find out other autoimmune association. And for finding out the autoimmune association, there is a mnemonic called DAT, CPR, MB. D for diabetes, A for Addison's, T for thyroid, celiac disease, pernicious anemia, rheumatoid arthritis, myasthenia gravis, and vitiligo. I will teach you one by one how to exclude each one. So this will be, you have done this from only the history. Remember that. Then come to the physical examination. Is it clear to everyone? Dr. Neha or Dr. Nujhat, are you clear about how to confirm from the history, how to find out the cause, complication, and then how to find out the association?
Happy.
Okay. Then from the physical examination. So from the physical examination, first you have to confirm that this is swallowing difficulty. Actually, there is nothing in the physical examination the way you can confirm the swallowing difficulty. So this is a meaning that this CCCA does not fit to every aspect of history, physical examination, and investigation. But you have to look for that. And I will teach each case by case, how to find out the cause, how to find out how to confirm, how to find out the cause, how to find out the complication, and how to find out the association. But to find out the cause or trigger, you have to do the examination of the myasthenia gravis. This is physical examination. Then for the complication, you have to auscultate the lung to exclude aspiration pneumonia. And then comes the association. So in the physical examination, to associate to exclude the association, you have to examine for double vision. You have to offer bedside forced vital capacity to exclude respiratory failure. And you have to do some other examination like bedside blood sugar measurement to exclude diabetes, postural to measure the sitting and standing blood pressure, to exclude Addison's. Then you have to assess for the neck swelling to exclude thyroid, and this all. You have to look for the anemia to exclude pernicious anemia. In this way, you have to do the physical examination to rule out the other association of myasthenia gravis and swallowing difficulty. Is this clear to everyone, how to do the physical examination? If I can get some feedback, it will be easier for me that whether you are able to understand or not. Okay, let's come to the next, that is investigation. So first, this is swallowing difficulty. How to confirm that this is swallowing difficulty? As in the myasthenia gravis, the swallowing difficulty is oropharyngeal. To confirm the oropharyngeal dysphagia, we have to do the esophageal manometry. Then to find out the cause or trigger, we have to do the investigation of myasthenia gravis that are anti-acetylcholine antibody and anti-mask antibody, and also single fiber electromyography and some that's all. Then to find out the complication, you have to do the chest X-ray. And to find out the association, you have to do the spirometry, looking for respiratory failure, measure the fasting blood sugar and HbA1c, thyroid function test, CBC looking for anemia, and that's all. Is this clear? How to, from the history, physical examination, and investigation, you can divide it into confirm, cause or trigger, complication, and association. Please, if it inform me if it is not clear. Dr. Neha, I'm seeing Dr. Anwar, and please inform me whether you were able to understand it or not.
Yes, sir. Yes, sir, it's clear.
Do you have any question regarding how to confirm and find out the cause or complication and association?
No, sir.
Okay. Now let's start discussing about the mark sheet. So this will be the mark sheet which will be provided in each station. And this mark sheet will be distributed to both the examiner, one for each examiner. And for each examiner, he will be able to give you only 14 marks out of 28 marks. And for each skill, if he is satisfied, he will give you satisfactory. If he is not that much satisfied, he will give you a borderline. So if he is satisfactory, he can at best give you 2 marks. And if he is not satisfactory, he can give you only 1 mark. Then if it is unsatisfactory, you will give 0. So in the physical examination, first you have to do the relevant physical examination. Examination of the prompt, then physical examination to find out the cause and complication, and also association. If you do in such way, you will get the satisfactory mark, that is 2 out of 2. And both the examiner will give you 4 marks. 2 plus 2 is equal to 4. And in our course, I will provide all the details of the 250 cases, how to do the physical examination for each case separately. I will give you the recording of that. Then identifying physical sign. For this identifying physical signs, I want to tell you something different. Actually, in the PACES exam, there are 2 types of patient. Sometimes, maximum cases, the patient is real. But in some cases, there is surrogate patient, that is dummy patient. And there are certain prompts which can come in the form of dummy. So if the patient is a surrogate and not real patient, at that patient, you will not find any positive physical finding. So in that case, there is no positive physical finding, so you'll get the full mark. But remember, in case of PACES exam, omitting is preferred than committing. So what does this mean? This means that you cannot synthesize anything. If you synthesize anything, like any mark that is not there, then you will lose all the mark in the identifying physical sign, even if you have identified some good physical sign. So be careful whenever you are going to tell about some positive physical findings. If you are not sure enough, don't go for that. This will be my advice, because omitting is preferred than committing in PACES exam. If you synthesize a physical sign which is not there, you will lose all the mark in the identifying physical sign. Remember that. Then clinical communication skill. So in the clinical communication skill, this is the thing that most candidates suffer. And in our course, we'll make it more easier. How to approach to the clinical communication skill. Actually, clinical communication skill falls under the prompt of under the heading of history taking. That is how to take the history, how you are going to elaborate each symptom, how you are going to exclude the differential diagnosis, and whether you are touching every point of the history taking. I will give you mnemonic how to touch each point separately, and whether you are telling the important safety netting, whether you are uh, 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 talking to the patient in a professional manner. This will fall under the category of clinical communication skill. And for each examiner, they'll be able to give you only 2 marks for taking a proper clinical history. I will discuss this during our whole course. Then come to the differential diagnosis. So try to tell at least 3 differential diagnoses for each prompt. And whenever you are going to tell the definitive diagnosis, put it in the first. That I have 3 differential diagnoses. My first differential diagnosis is this is a case of myasthenia gravis. For this oropharyngeal dysphagia, my first differential diagnosis is myasthenia gravis. But for this oropharyngeal dysphagia, I have many other differential diagnoses. Like it can be case of stroke. But against that, always tell always tell the excluding criteria. Like it can be stroke, but against that, from the history and physical examination, I have not found any evidence of hemiplegia. The cause of this oropharyngeal dysphagia can be polymyositis. But from the history and physical examination, I have not found any evidence of weakness. So in this way, you have to tell the differential diagnosis. But keep the provisional diagnosis as the first. And there are certain prompts for the PACES exam where you have to keep certain differential diagnosis in the top 1 portion. Let me give an example. In the PACES exam, whenever a chest pain comes, in more than 90% of cases, this chest pain is due to pulmonary embolism. Remember this thing. In more than 90% of cases, when a chest pain comes in the PACES exam, it is pulmonary embolism. So you have to look at the clue, whether there is any evidence of pulmonary, whether there is any immobilization there, like long-term flight or any history of SLE. In that case, you have to utter the word pulmonary embolism as your first differential diagnosis, not a second or third one, because the British examiner are very much sensitive about the pulmonary embolism. So it will be discussed along the course how to what to tell in our first differential diagnosis, then second and third one. But it is not that much rigid. It is very much easy. Actually, long clinical consultation is very easy station. If you go in a certain way, if you go approach this station in a technical way, it is very much easy. And there are certain prompts which comes again and again. You have to master how to approach to each prompt, how to take history for each prompt, how to exclude the differential diagnosis. I will give you all the guides needed to make you the perfect in the long clinical consultation. Then comes the point of clinical judgment. So in the clinical judgment, sometimes the candidate thinks that I have to know a lot to cover this area. Actually, this is the wrong idea. The thing you have to know must to get the 2 out of 2. Every examiner has 2 marks to give you in this clinical judgment. So you have how to get these 2 marks. The 2 marks is you have to know the investigation and management. Only these 2 things. And you have to be organized how to tell the investigation. You have to tell it like investigation to confirm my diagnosis, then investigation to confirm the cause or find out the cause, then investigation to find out the complication, then investigation to rule out the association. I will give a recording of each and every cases, that the 250 cases, how to tell the investigation for each cases separately. And you have to utter it by yourself. You have to memorize it. And in the examination, you have to tell it in a certain way. Like whenever you have, I will teach one by one. And in the how to tell the management. So there are 2 types of case in the PACES exam. One is stable case, and another one is acute case. So in case of stable case, you have to start with the education and counseling, forming a multidisciplinary team. Then treatment of the underlying cause. Stop at that point. Don't tell anything else. Also, you can tell treatment of the complication. Then the examiner will invite question to you that suppose the underlying cause is myasthenia gravis, what will you treat? But let the examiner ask you the question. Don't keep all the answer in one go, because if you give all the answer in one go, the examiner will ask you the next question, and this sometimes can put you into trouble. Although if you can cover the investigation and management, no examiner will cut any mark. But if you are not able to answer certain questions, it will create a pressure inside your mind that will create that will affect your next station. So better not to give all the answer in one go. I will discuss it during our during the whole course session, and after the end of the course, we will be able how to go through this technique. Okay. One is stable case, and another one is acute case. So how to approach to the management of acute case? You have to start like this. First, admit the patient. For all acute case, you have to admit the patient. And second, you have to tell management of the ABC. That is airway, breathing, and circulation. Then you can go for education and counseling, forming a multidisciplinary team. Then treatment of the underlying cause. Later, treatment of the complication. So you have to approach in this way, and you have to prepare earlier during taking preparation, how to go for how to answer for each case. And I will suggest you to give the answer in slow pace, not to give the answer in hurry, because if you answer all the questions, then the examiner will ask you next question. Although if you are able to tell the investigation and management, you will get the full mark. But sometimes, whenever time's left, the examiner continues to ask the question, which can create some pressure inside your mind, which can affect the next station. So there are certain techniques how to give the answer to the examiner, and I will discuss during our session how to discuss for how to give the answer for each cases. Then managing patient concern. Again, each examiner is allowed to give at least at best 2 marks if he is satisfied, and borderline 1 mark. If he is not satisfied, then no mark. So in the PACES station, in the long clinical station, you will be allowed 15 minutes to deal with the patient and 5 minutes with the examiner. In this 15 minutes, after 30 minutes, you will be given an alarm, like you have 2 minutes left. So in this case, I will suggest everyone that keep these 2 minutes only to meet the concern of the patient, nothing else. Because there are so many, sometimes there are so many concerns, sometimes there are 5 to 6 concerns that the patient has to ask you. These are very easy concerns to meet, like why I'm having this problem. Do I need to get admission? Do I have brain stroke? Do I have brain tumor? Do I need CT scan? So you need at least 2 minutes to meet all the concerns. So this is very easy to gain. So you have to practice again and again so that you will be able to finish the case within the 30 minutes and meet the concern of the patient. Then come to the patient welfare. Actually, everyone gets the full mark here. Just remember that don't make any pain to the patient. If you are conscious enough not to make any pain and maintain the proper hygiene, like hand wash, you'll be able to get the full mark in this case. So these are all about the skills of the long clinical consultation. Regarding this, do anyone have any kind of question? If anyone has any kind of question, please feel free to ask me. I will try to explain it. Dr. Mahfouz, Dr. Neha, anyone have any kind of question regarding the mark sheet? Okay. So let's proceed further. Now I'm going to discuss the approach to the clinical communication skill. That is the history taking. This is the most difficult part that every candidates face. So this course is almost about this skill, that is clinical communication skill. And also, I will also discuss how to tell the differential diagnosis, and I will also give the recording of all the cases of physical examination and identifying physical sign. So let's start. So up to now, do anyone have any kind of confusion regarding the triple CA? Because this is very much important. I'd like to hear from the candidates. Like I'm saying,
No,
Dr.
sir.
Okay, Dr. Neha is clear. Is everyone clear? Okay. Let me discuss the format. So this is the format of history taking. First, you have to do the introduction. Then you have to do the symptom analysis. Then you have to do the systemic review. Then PDF Sajid, and then do the examination and consent. I am going to discuss one by one. So how to do the introduction? After entering into the station, actually before entering into the station, you will be given a scenario in a page that this patient has come with swallowing difficulty. You will be given the name of the patient, like Mr. Jackson, 30 years old, has come to you with swallowing difficulty. Please examine him, meet his concern, and please examine him, talk to him, examine him, and meet his concern. So, and you will be given a blank page with pencil and rubber. You can take your necessary notes at that blank page. So after entering the station, there will be an examiner who will welcome you. So after that, you have to talk to the patient. How to start? So first you have to tell that, hello doctor, I am doctor. You have to start a surname. I am Dr. Day, one of the doctors working here today. Try to keep a smiley face. This will put a good impression to the examiner. Then I have to tell, I am here to talk to you about a problem and examine you. Is that okay? If at any point you have any question, please feel free to interrupt me anytime. I may take a few notes during our conversation, but rest assured that everything remains confidential. In the PACES exam, confidentiality is a big issue. So try to tell this thing. Whatever you are going to know, whatever you are going to do, whatever notes you are going to take out of the patient, it will remain confidential. You have to make it sure to the patient. Then you have to ask the open question. That's so in your own words, can you please tell me what brings you here today? So this is something like introduction. You can also use your own word, how to tell the introduction. So there goes the introduction. Then come the symptom analysis. So this is actually a mnemonic of symptom analysis. Excuse me. So the mnemonic is Odipara. O goes for onset. Onset means how did it started? Did it start suddenly or gradually? D means duration. For how long he is having this symptom. I means initial episode, whether this is the first time he or she having this kind of problem. Then P means progression. Is it gradually increasing or decreasing? A means aggravating factor, R means relieving factor. Anything increase it or decrease it. Then A goes for associated features. This is mnemonic, that is Odipara. We have to analyze every symptom using the Odipara. But remember, there are certain prompts where you cannot use the mnemonic Odipara. And I will guide you, I will give you specific notes, what questions to be asked during that prompt. Then for pain, this is my mnemonic, that is LICO. So L goes for location. You have to specify, where do you feel the pain? This LICO is only for pain. You have to determine the intensity. You have to determine the quality, giving some example like, is it dull pain, sharp pain? And you have to determine the radiation. Does the pain goes anywhere? This is something like that. I will keep the PDF sheet to the active participants in the inbox. We can learn it from there. What I'm going to do special is that Usually, every candidate, what does they do? After introduction and symptom analysis, they go to the systemic review. But there is a trick. What is that trick? The trick is that actually PDF, let me tell you what does PDF mean. PDF means past medical history, drug history, and family history. So if you want to catch the diagnosis earlier, after symptom analysis, go to the PDF. And I can guarantee you, in more than 80% of the cases, you will get your diagnosis. This is certain trick for PCS exam. I'm telling it once again. After doing the symptom analysis, go direct to the PDF. If you go to the PDF earlier, you will get your diagnosis and you will be able to remain focused. Let me give an example to you. At the Bangalore, a case came like fever. So the candidate who shared his experience with me, he was not getting any clue why this fever was there. So at last he was asking in the past medical history, do you have any past medical condition that I should be aware of? He was denying that I don't have any kind of past medical condition. Any surgery before? No surgery before. At last, when he asked any recent procedure, then the surrogate replied that yes, I had recent dental procedure. So what can be the diagnosis here? Can anyone tell?
Infective endocarditis.
Wonderful. Infective endocarditis. That's why past medical history, drug history, and family history is very much important. After analyzing the symptoms, if you directly go to the past medical history or drug history or family history, you will get your diagnosis in more than 80% of cases. This is a hidden trick of PCS exam. I'm giving another example. Like in the Delhi, there is a common case. This is also a fever, a case of fever. So during asking the past medical condition, if you after analyzing the fever, that how did it started or gradually, was the highest recorded temperature. So after you ask, what do you have any past medical condition that I should be aware of? The candidate, the surrogate replied, yes, I have kidney problem and I undergo regular dialysis. So what can be the cause of fever in this patient? Can anyone reply?
If it's a catheter, then catheter-related bloodstream infection. If it is a AV
Wonderful.
fistula, then infected AV
Yes,
fistula.
the diagnosis is infected
Mhm.
AV fistula. This is very much important. I'm giving another two examples. There is a case every now and then comes with a prompt of hematuria. That is blood in the urine. So after asking the past medical history, you will not get any clue here. During taking the drug history, no clue there. But in the family history, the patient tells you that my father died of brain stroke. Bleeding, that is bleeding inside the brain. So what can be the cause of hematuria in this patient? Can anyone tell me or respond? Let me see. What can be the cause of hematuria in a patient? That is painful hematuria with a family history of brain stroke.
ADPKD.
Wonderful, Dr. Neha. ADPKD. Because probably his father died because of intracerebral hemorrhage. Let me give another example. A case come with a prompt of sore throat. So after going to the PDF, in the drug portion, you are getting that he is taking carbimazole. So what can be the cause of sore throat in this case? Can anyone reply?
Agranulocytosis.
Wonderful, agranulocytosis. Actually, this is a hidden trick of PCS exam. After analyzing the initial symptom, if you directly go to the past medical history, drug history, or family history, you will get your diagnosis in more than 90% of cases. And this is my guarantee to you. But the thing you have to know that these are the 7 questions you have to memorize, because in the exam, you will not get any time. What question you have to ask? Because I'm giving my example. I gave example during my diet. I was given a case of headache with fever. So I asked, do you have any past medical condition that I should be aware of? He denied that I don't have any past medical condition. Then I asked, any surgery before? He replied that yes, I had a road traffic accident and I had some surgery in my tummy. So I asked him, can you please remember which surgery, what is the name of the surgery? He denied that I cannot remember. So I look at the scar mark and this was a splenectomy scar. So can anyone guess what is the diagnosis in this case? What is the cause of meningitis?
Encapsulated organism because he did not take vaccine.
Wonderful, very good, very good. At that time, I directly asked him, did you take the shots as recommended by the doctor? He denied that I could not take the shots. I also asked him, did you take the antibiotic prescribed by the doctor? He also replied that I just could not take the antibiotic. And that point, I got my diagnosis that this is due to meningitis due to encapsulated bacteria. I got 28 out of 28 in both the cases, both the long clinical consultation. And this is a wonderful tip, directly going to the past medical history, drug history, and family history after analyzing the symptom with the OD para. And I am guaranteeing you that you will get your diagnosis in more than 90% of cases. And remember these tricks every now and then. Is this clear? And what questions you have to ask during past medical history? I have written all the questions here. There are 7 questions. You have to memorize these 7 points because in the exam there is no time to think and ask question. You have to memorize these 7 questions during the past medical history. And during the drug history, for PACES exam, the British examiner are very much sensitive to one question here. That is allergy to any medication. Remember, there is no significance to the relevant diagnosis here. But the British wants that whether you are assessing whether there is any allergy to any medication. In this diet, in the Pondicherry, I have talked to a candidate. He told me that there's a Chinese examiner, a lady. After taking the history, she asked, did you take the allergy history? So this is very much important for British examiner. Exclude the allergy. And you have to ask these 7 questions. I will suggest you to memorize these 7 points. Then the family history, you have to ask only 2 questions. Any disease running in the family, any one of the family members having similar problem. So this goes for the PDF. I will tell again, after analyzing the symptom, directly go to the PDF. You will get to a diagnosis. So this is the PDF. Then what goes for 5P and Sajid? So let me tell you. Sajid means you all know smoking, alcohol, job, impaction on daily life, and driving. Remember, impaction on daily life. This is a very much important point for PACES exam. You have to ask how these symptoms affect your job and daily activity. Because by these things, you are ruling out the complication from the history. Like if the patient is that for this swallowing difficulty, I'm not able to take the food. For this shakiness of hand, that is tremor, I'm not able to do the daily activity. So can anyone tell me if someone tells that for this tremor or hand shaking, I am not able to do the daily activity, like the hand washing, like the clothing, bathing. At that point, what specific service you have to offer to the patient? Can anyone tell me?
Social worker support to help.
Wonderful. Wonderful. Yes, social worker support. That's why this is important. Sometimes the patient can tell you that for this fever, I'm not able to attend my job. I'm not able to attend my office. At that point, you can offer some help that if you want, we can offer you some sick letter. So this is that much important. You have to assess impaction on job and daily life. Then come to the driving. So there are certain cases where you have to stop the driving. And at certain cases, you don't have to. Sometimes you are confused whether you have to stop driving or not. At that case, the safe side is you have to tell, I will suggest you to stop driving till further assessment. Remember this thing. In the PACES exam, you don't need to know everything about the DVLA because this is a separate department. You can refer the patient to that department. They will give the details, how long he can drive, how long he cannot drive. That information will be available at the DVLA. So you don't have to know all the details of the DVLA. Sometimes many candidates spend their time memorizing the time frame for which disease, how many times they cannot drive, for how long he cannot drive. But this is absolutely no need. If you're not sure whether he cannot drive or can drive, just tell stop driving till further assessment. And you will be in the safe side. These are some tricks. So this goes for surgery. Then come to the 5P. 5P means actually female history. That is period, pregnancy, abortion, and partner. For remembering, I have converted the abortion into abortion. For every reproductive age female, you have to take this 5P history. That is period, pregnancy, abortion, and partner. Sorry, one slide is missing here. Then come to the point. What comes for point? Actually, I'm sorry, one slide is missing from here. P goes for period, pregnancy, abortion, and partner. So you have to take this 5P history in case of any reproductive age female. Then comes to the point. What comes for point? Actually, points go for partner history. Sorry, not partner, pet history. O for occupation. E for exposure. And T for travel. Actually, you don't have to take pet history, occupation history, sexual exposure history, and travel history for all the prompt. But there are 4 prompts where you have to take these 4 history. What are the 4 prompts? The 4 prompts are, they are cough, diarrhea, then fever, and joint pain. So whenever these 4 prompts come, you have to take the POET history, that is pet history, occupation history, sexual exposure, and travel. Let me give an example for you. A case came at one diet. The patient has cough, that is dry cough. And regarding the pet history, he has hobby of pigeon. He's a pigeon lover. So what can be the case here? Can anyone tell me? What can be the diagnosis in this case?
Pneumonia tuberculosis.
Extrinsic allergic alveolitis.
Yes, this is hypersensitivity pneumonitis. In this case, he will get capitation at the upper lobe. This is a real PACES exam cases. Let me give you another example. Like the patient has also cough, that is dry cough, and the patient occupation is painter. So what can be the cause here? What can be the diagnosis in this?
Bronchial asthma.
Yes. Also in that case, it was hypersensitivity pneumonitis due to some painting. Are you getting my point? Then in the diarrhea, you have to take POET history. In the fever, you have to take the POET history, like the sexual exposure in a casual sexual partner. You have to take the travel history. Also in case of joint pain. So cough, diarrhea, fever, and joint pain, you have to take the pet history, occupation history, sexual history, and travel history. For remembering, I am telling you the POET. And regarding the travel history, how to take the travel history? You have to divide it into 3 parts: before, during, and after. Before, you have to ask, did you take any preventive medicine? And during, you have to ask for how long you are staying there. Where did you stay? Did you stay in the hotel or camps? Contact. During your stay, I'm sorry to ask you some personal question. I'm regarding this thing, the sorry I'm telling, when I'm asking some personal question, always tell the patient I'm sorry. Then after telling sorry, you have to ask any unprotected sexual contact, any contact with cattle or sheep, any contact with sick patient, insect bite, swimming, any contact with swimming pool. And after travel, did you continue with preventive medicine after coming back? These are the questions for the travel history. I will provide it as a PDF to all of you. So there goes the PDF, POET, 5P, and Sajid. Is this clear to everyone? Do anyone have any kind of question regarding what does PDF mean? Because PDF is very much important to get to the diagnosis in case of basis exam. And POET is important in case of 4 problems: cough, diarrhea, fever, and joint pain. And you have to assess the 5P for any reproductive age group female. And also you have to take the history of SAGI, that is smoking, alcohol, job, impact on job and daily life, and driving. If you miss any point from the PDF and SAGI, you will lose your mark in the clinical communication skill. That's why I will suggest everyone to write in the blank paper outside the examination room the mnemonic, that is PDF SAGI. Whenever you ask one thing, that put a tick mark over there. Then come to the systemic review. Regarding the systemic review, I will provide you a list of questions. What questions you have to ask? I am discussing it. Actually, this is not that much important. The importance is that whenever you come to a diagnosis, you have to cover that system questions first and then to the relevant system. It is very much easy. After starting the practice, you will get to that. But I am going to discuss about the systemic questions a little bit. For any, whenever you want to exclude any chronic infection or any cancer, ask the triple L. What are the triple L? That is loss of weight, loss of appetite, lumps and bumps in the body. And ask the triple F. What is a triple F? The triple F is fever, fatigue or tiredness, feeling sick or nausea. So these are the systemic questions for any prompt. Then the CNS questions are headache, dizziness, uneasiness, fits, double vision, drooping of eyelids. You have to ask that question from the head, eye, mouth, limbs, and the genitalia. So you have to just memorize these questions. Suppose a patient has the prompt is weakness, that is due to hemiparesis. At that time, you have to ask all the CNS questions. This is the rule. If the prompt is from the chest pain or palpitation, you have to ask the cardiac and respiratory questions. So what are the cardiac questions? There are 4P. That is pain, breathing, palpitation, and pitting edema. That is pain in the chest, breathing difficulty while lying down, waking you from sleep. Palpitation means racing and pacing of heart, and leg swelling. That is pitting edema. The respiratory screening questions are any runny nose, nasal blockage that you can get in granulomatosis, in polyangiitis. You can get nasal blockage, then throat pain, then cough, noisy chest, bloody cough. Sorry. In the gastro, you have to ask difficulty in swallowing, heart pain, acid burn, tummy pain, tummy distension, change in bowel habit, change in the color of eyes. That is jaundice. Excuse me. The renal questions are change in the water work. That is amount, color, frequency, frothiness. This renal question you have to ask for every prompt. Actually, this will be clear during discussion of every prompt and practicing it. Then any gravels passing through the urine, any puffiness around your face, any leg swelling. For musculoskeletal and rheumatological screening, you have to ask joint pain, skin rash, stiffness, and skin rash after going to the sun. In certain cases, the patient will not reply you whether she is having any skin rash. But if you ask her whether she is having any skin rash after going to the sun, at that time, she will reply you that I am having some facial rash after going to the sun. And at that point, you have to safety net that avoid sun exposure or use some sun protective medication. Then for endocrine, any neck swelling, any heat, double H, heat intolerance, handshake, that is tremor, double C, cold intolerance, constipation, any change in ring size or shoe size. So these are the systemic questions. So we have covered introduction, symptom analysis, systemic review, PDF, 5P, Sajid, and POET. Is this clear to everyone? Do anyone have any kind of confusion regarding how to approach for systemic analysis, for symptom analysis, then systemic review, then PDF by 5P, Sajid? Okay. Then you have to examine the patient. Then you have to meet the consent. You will be provided at least 2 minutes. I will suggest whenever the examiner tells you that you have 2 minutes left, directly go to the meeting the consent. So these are all about how to approach for certain case in the basis examination in the long clinical consultation. I've also put here certain things like the diabetes questionnaire. When a patient comes to you with long-term high blood sugar, like more than 10 years, you have to ask this question. So what are the questions? I have put it here. I will provide you the PDF. You have to ask these questions. So you have to ask, like, do you have any high blood sugar? For how long? How it was diagnosed? What medication you are taking for this? What is your last 3 months HbA1c report? Do you go to a eye doctor, kidney doctor, and food doctor? Then you have to assess the compliance for 3D. That is diet, drug, and daily exercise. Are you compliant with the medication? Are you following the recommended diabetic diet? Are you doing regular physical exercise? Then you have to assess the complication. Any episode of low blood sugar or hypoglycemia, any episode of high blood sugar or HSDK. Actually, diabetic questionnaire is very much important. Whenever a case comes to you as a long-term diabetic patient, you have to ask this question. Then you have to exclude the microvascular complication, macrovascular complication, and the autonomy. I will suggest you to memorize these points, and I will provide the PDF to you. Then these are the rheumatological screening questions. Whenever you find any evidence of any rheumatological evidence, you have to ask all these questions. You have to start from the name. Like from the finger, you have to ask any change in the color of finger upon exposure to the cold, that is Raynaud's. Then joint pain, stiffness, skin thickening, difficulty in raising arm, any hair fall, any grittiness of mouth or eyes, any eye redness or eye pain, any skin rash, any rash after going to the sun, mouth sore, chest pain, tummy pain, change in the urine. So these are the rheumatological screening questions. You don't have to ask all the questions. Whenever you get a clue that there can be some evidence of rheumatological disease, at that time, you have to ask all the questions. So these are the questions. So these are the questions for rheumatological screening. So this is all about approach, general approach to any prompt in the basis examination. If it is clear, then I can start discussing about the musculoskeletal prompts. Is everyone clear about what I have discussed so far, how the marks is distributed, what is the trick to reach the diagnosis earlier? Do anyone have any question regarding this? Please feel free to ask me. I'll be happy to answer the question. Any question from the participants? Just give me a signal that it is okay, then I can proceed to discuss the musculoskeletal system.
Okay, doctor, you can proceed.
Okay. Now let's discuss the gem of this course. So actually there are many systems that I have divided the prompts that are musculoskeletal system, the gastroenterology and the GIT system, the neurological system, that are cardiovascular, respiratory, endocrine, renal, dermatology, and miscellaneous. In this way, we proceed our courses. For each system, I have identified certain prompts from the last 3 years that comes again and again. And after completing this course, if you go through the every diet exam cases, you will find that rarely any cases comes out of these prompts. And I can guarantee you, you will get common of your more than 95% of the cases. This is guarantee from my side. I cannot take guarantee for less than 5% of cases, but I can guarantee you that you will get common from this list for more than 95% of the cases. Because there's a pattern in the PACES exam, which cases come and which cases does not come. So let's discuss one by one. So from the musculoskeletal system, these are the prompts that comes in the PACES exam. That are hand pain, low back pain, knee pain, ankle pain. And the first four prompts are the most important one because these prompts comes every now and then in the PACES exam. And musculoskeletal system is the most important prompt for the PACES exam. And in fact, in every diet, in every carousel, you will get at least one musculoskeletal case. So what are I have divided these prompts into 3 types. They are triple star, double star, and 1 star. Triple star means they are very much important. Double star means they are medium important. And 1 star means they are least important. So let's start with discussing the triple star cases. First, start with the hand pain. So in the PACES exam, you will be given a scenario like this gentleman, Mr. Jackson, has come with hand pain. You will be provided with some vitals. Then you have to, the instruction will be talk to the patient, examine him, and meet his concern. So how to approach to a case of hand pain? After entering the session, after doing necessary introduction, you have to ask, what do you mean by hand pain exactly? Is it color? Because in the PACES exam, hand pains come only for 4 scenarios. They are Raynaud's, either Raynaud's or joint pain or carpal tunnel syndrome or AV fistula. Apart from these 4 scenarios, hand pain does not come. So you have to ask, what do you mean by hand pain exactly? Is it color change on exposure to the cold, that is Raynaud's? Or is it joint pain? Or is it tingling and numbness, which is relieved by shaking and cold water, that is carpal tunnel syndrome? You have to ask this specific question. Sometimes hand pain can be due to the blocked AV fistula or infected AV fistula. You can get the idea of AV fistula from the past medical history. In the past medical history, the patient will tell you that I have kidney problem and I'm undergoing regular dialysis through my catheter. You have to ask the patient, where do you feel the pain exactly? Can you please show me the sign? This is a very much important question because if you don't ask this question, you will lose your mark. In the Dhaka Center, a case came with a prompt of hand pain, and the hand pain was due to carpal tunnel syndrome. And the candidate didn't ask, can you please show me the site? Only for not asking this question, the British examiner deducted 1 mark in the clinical communication skill. So at first you have to ask, what do you mean by hand pain exactly? Exactly. You have to give some example, like is it color change on exposure to the cold? Or is it joint pain? Or is it tingling and numbness, which is relieved by shaking and cold water? Can you show me the site? Where do you feel the pain? If he show you the site that he is feeling pain over the hand, over the AV fistula site, then it is due to the infected AV fistula. So after that, you have to analyze the hand pain using the mnemonic ODPARA. That how did it started? Did it start suddenly or gradually? Is it the first time? Is it gradually increasing or decreasing? Anything increase it or decrease it? And the associated symptoms. So this is the initial question for hand pain. Now let's come one by one. For Raynaud's, in the PACES exam, systemic sclerosis comes with a prompt of Raynaud. And the systemic sclerosis patient will be identified only by seeing the patient. You have to ask the screening questions of the rheumatological screening question. These are. So systemic sclerosis mainly comes for, hand pain with Raynaud syndrome mainly comes with systemic sclerosis in the PCS exam. Remember this thing. It can be given also MCTD. But usually SLE or other rheumatological disease usually does not come. But you have to exclude. Then come to the joint pain. So what are the joint pain? There are two types of joint pain. One is with morning stiffness and another is no morning stiffness. If there is morning stiffness, then the diagnosis is seronegative spondyloarthritis or rheumatoid arthritis or SLE. And if there is no morning stiffness, it can be osteoarthritis or gout. And in case of spondyloarthritis, seronegative spondyloarthritis, the common cases come in the PCS exam are psoriatic arthritis and reactive arthritis. So remember this thing. I will give you real cases to practice. Okay. Then come to the next thing, that is carpal tunnel syndrome. So for carpal tunnel syndrome, the differential diagnosis of bilateral carpal tunnel syndrome is cervical myelopathy and peripheral neuropathy. And remember, a case came in the Dhaka center, that is bilateral carpal tunnel syndrome. And the candidate did not examine the Hoffman sign and the bilateral supinator jerk. And he lost his mark. Because by checking the jerk of both hands, you are excluding the cervical myelopathy. Remember this thing. This is very much important. So what are the causes of carpal tunnel syndrome? In the PCS exam, almost every case is due to it is due to the complication of weight gain. This weight gain can be generalized or localized. And also you can remember the mnemonic RAT, that is rheumatoid arthritis, amyloidosis, and T for trauma, tumor, and trimming. It means trauma to the hand, tumor, and trimming. Trimming means he is doing some hand activity, like vibration or something like that. So RAT codes for rheumatoid arthritis, amyloidosis, trauma, tumor, and trimming. Actually, in the PCS exam, almost all of the cases, carpal tunnel syndrome comes against the background of weight gain. This weight gain can be localized or generalized. If it is localized, then either acromegaly or Cushing. If it is generalized, then it can be hypothyroidism or PCOS or simple obesity. Remember this thing. So this is carpal tunnel syndrome. Then come the next cause of hand pain, that is AV fistula. So the cause of AV fistula pain is due to the infected AV fistula or blocked AV fistula or cellulitis. These are the three causes of hand pain due to AV fistula. Is it clear to everyone? What are the causes of hand pain in AV fistula? Is it clear?
Yes, sir.
Okay. Then in case of hand pain, you have to utter some safety netting. Like if it is Raynaud's phenomenon, you have to do some safety netting like avoid cold exposure and use gloves while going outside in the cold. And in the history, if she tells that she is taking beta blocker, you have to stop that. In the history, she tells that she takes OCP. You have to stop that. Regarding OCP, let me tell you one important thing. Whenever in the history, anyone tells you that she takes path contouring pill, and from the history, and you are thinking that you have to stop that path contouring pill, you have to tell the patient that stop the path contouring pill And I am referring you to the women doctor to offer you some safe alternative. So for Raynaud's phenomenon, you have to do some safety netting. And for carpal tunnel syndrome, you have to also offer some safety netting. Carpal tunnel syndrome, if the job of the patient is doing some office work and he is typing, his job is typing, then you have to change the job. You have to tell that you have to, this job can aggravative symptom. For that, I'm going to refer you to the occupational health clinic. How does that sound? So you have to do the safety netting for Raynaud's phenomenon and carpal tunnel syndrome. Then, for all cases of hand pain, you have to examine the functional capacity of the hand. This is very much important. By checking the functional capacity, you are excluding the complication of hand pain by physical examination. So how to check the functional capacity of the hand? You have to tell the patient that, can you please make a fist and open it for me? And second, you have to tell that, can you please button and unbutton your shirt for me? This way, you can assess the functional capacity of the hand. Is this clear to everyone? How to approach to a case of hand pain? Then I can ask you some questions, like real case scenario from the exam. And let's see who can answer. Any question from the approach to hand pain? Let me say you. Dr. Anwar, do you have any question? Dr. Asifur, Dr. M, Dr. Nita, any kind of question from anyone? Okay. Okay, AV fistula pain due to what 3 causes? Okay, let me tell you once again, what are the causes of AV fistula pain? Whenever the hand pain is due to AV fistula, that you are seeing the patient is having AV fistula. He is having this pain probably due to some infected AV fistula. Remember, then it can be due to blocked AV fistula. Or it can be due to cellulitis of the surrounding skin. There is another 4th cause, that is ischemic Steele syndrome. This is not that much important. The first 3 is very much important. Is this clear? The term infected AV fistula. Actually, this case came in the Delhi. So for some unknown reason, the examiner preferred the word infected AV fistula. So the candidates who replied that this is thrombophlebitis, they did not like this term. I don't know why, but they like the term infected AV fistula. They don't like the term thrombophlebitis. It is true for Delhi. They gave in the feedback that the candidate uttered the term thrombophlebitis. Rather, you have to tell it, it is infected AV fistula. I have directly seen the feedback of the candidate. So let me give you some real exam cases, and I will expect the interaction from each candidate. These are real exam cases. So at one time, from my experience, I appeared in the Bangalore. So my case was a 45-year-old male with hand pain. So after entering the station, whenever I asked, what do you mean by hand pain exactly? Is it color change on exposure to the cold, or is it joint pain, or is it tingling and numbness, which is relieved by shaking? He replied me that I have joint pain. Then I asked, do you have any morning jamming? He replied me that yes. And he had some skin rash. So can anyone reply me? What is the